For Dr. Gazmuri, you were talking about norepinephrine as not being the ideal solution for circulatory failure. Can you just elaborate further, because it was at the end of the lecture and we didn't get that restructuring of the JAMA results?
Yeah, of course I will acknowledge that I am really in the minority. There's a big push, probably with good justification by the people who propose that, to the use of vasopressors. And I believe if you're going to use a vasopressor, norepinephrine is a good choice. There was a recent study showing that, so I said vasopressin, I mean norepinephrine. There's a recent study, the Advantage study, that showed that vasopressin does about the same. My experience at the bedside is the following, that once a decision is made to start somebody on a vasopressor, the order is typically written as titration within certain range to a given pressure. And there's little follow-up after that. Now, a patient who is in septic shock, this is what we're discussing here, it's a very dynamic process. And it's not unlikely that a patient who might have been successfully fluid resuscitated at the beginning may become fluid deficit over time because of the nature of the disease, and a decrease in blood pressure that will benefit from fluid could be to increase the level of the vasopressor, meaning that we're not treating the patient most appropriately because we'll rely on something that is easier to use. Now, regarding your specific question about that table, I thought it was interesting that the groups of patients in that analysis, there are about 18,000 patients, were grouped based on whether or not they remain hypotensive after giving fluids, and by different levels of lactate in the blood. So if you compare the groups for those characteristics and look at mortality that was reported in that table, it just happened that the patient who were on a vasopressor had higher mortality. Now, I'm not saying that that was the reason for that. Maybe those patients were sicker, that was not captured in the way the data was analyzed, but I think we should look into that. And the other things we can discuss, the underlying pathophysiology. What does it mean to be vasodilated? Does it mean, that means that some organs are getting more flow for a given level of pressure. So when we give a vasopressor agent, we might be compromising certain organs that we're not aware of. I have experience of several cases in which I have focused on the perfusion, mental alertness, a good heart rate, and urine output, and allow the blood pressure to drop and not jump into a vasopressor agent, and patients have pulled through without much difficulties. So I just wanted to say that we need to revisit the concept. One more brief comment. If you look at the indication, at the data behind that, I mean, the guidelines admit that it's low quality. It's a level C. And if you start looking at the studies behind the recommendation, there's very little evidence that is solid to recommend that maintaining a blood pressure, a mean arterial more than 65, really improves outcome. And then we have the studies showing that different levels of blood pressure target do not alter the outcome. So there doesn't seem to be a dose response. That is my line of argument.
Thank you very much. Any other questions, comments? Nobody?